Please always consult with your physicians prior to making any changes to your treatment plan. Music is courtesy of Ryan Hamner. Welcome to Living with Scanxiety, the Cancer Podcast, a podcast geared to help you navigate the pediatric cancer world. As a mother of a child who battled a soft tissue sarcoma for over a year, your host, Rosaria Kozar, understands and will help guide you through your journey. She brings the knowledge of experts, families, survivors, and other organizations tied to the pediatric cancer world to your doorstep. Her mission is to inform, support, and promote hope for you and your family.
This is where hope lives. This is where hope thrives. Together as one, we all laugh and we cry. This is where hope breathes. A thousand stories.
Hi everyone, this is Rosaria Kozar, your host, and I am letting you know that you are tuning in to part 2 of Dr. Gonzalez's episode. You are going to learn a lot, and just as a reminder, this episode contains information about eye removal surgery. Thank you for coming back and tuning in.
I don't know. I'm kind of fascinated now. Like, this is
let me
some good detail.
Well,
So,
let me tell
yeah,
you.
you can-
Let me tell you something because okay, so we in the operating room there's the anesthesia doctor
yeah.
who put the patient and then there is an assistant of anesthesia, so also a resident or a fellow of anesthesia.
Mhm.
Then we have a nurse that is helping me with my instruments, and then we have a nurse that is in charge of the whole room, making sure that everything is, all the medications are there. If we need something, everything, she's coordinating everything. So we have a lot of, we have 2 nurses or 3 nurses sometimes. Then we have the surgeon, and then we have somebody who is sometimes assisting the surgeon or not. And then we have all the machines, right? All our cameras and our instrumentation and everything. So when we already know that we're going to remove the eye, or any surgery for that matter, we put the patient there. We do a couple of timeouts, okay? So first we do a timeout outside the room when said to the family, which eye are we gonna remove today? And they have to help us to point it out. We have to make sure that everything is correct, right? So we mark the eye, we put a lot of initials around the skin. Then we go inside and there's a couple of witnesses there. Then we go inside the room and then we do a timeout and say, hey, okay, we're gonna remove the right eye. Everybody agrees it's the right eye? Yeah. Let's open the chart. Is it the right eye, the one? Yes, it's the right eye. Is everybody agrees that the mark that I put is in the right eye? Yes, everybody agrees. Okay, perfect. Now, before we remove an eye, we take an extra step, even though everybody agrees already and we already did 2 or 3 timeouts, I actually go, before I actually remove the eye, I go and look again. And before I do it, I just look and make sure, okay, yes, this is the eye that I'm going to remove. This is the tumor that I'm going to remove. This is the eye, because I don't want, it will be devastating to remove the wrong eye, which, by the way, it can happen. Okay.
Yeah.
It has happened in the past.
The same thing happened with my son. Well, they took the right side, but so they had to come over, mark it with an X, and check with us and make sure that his knee disarticulation was on the right side. And so I've been there.
Well, let me tell you, now the X is forbidden because you can argue that the X is like, oh, this is not the leg, and then people can get confused. So the X is no longer something that we can do. Is we have to put our initials, EG or our initials, because some people can say, oh, X is, oh, this is not the eye, it's the other eye, right? No, so now we take a little bit more precaution.
Good,
anyway,
good.
So let's say that we already did all these timeouts and everything. So we put the patient, we clean the eye with a special solution to everything sterile. We cover all the face and we just leave the eye out. And then I tell the anesthesiologist, can I start? Is he, comfortable? Yeah. Okay, perfect. So then I have the white part of the eye, it's actually a couple of layers. The white part of the eye is the eyeball itself. And there's a layer that is, when you have pink eye, the pink is the skin of the eye. It's like a transparent layer that is on top of the white of the eye. So we have to cut that and try to remove that skin of the eye very carefully so we don't rip it or tear it. Then once we remove that part that is the pink, when you have pink eye, the skin of the eye, then we have the eyeball itself there. We see all the muscles around the eyeball. We have to go in and remove each muscle. Okay, we have 6 muscles. Okay, so we remove each of the 6 muscles, and we leave them there because we're going to need them later to put them in the prosthesis so it can have some movement. Okay, because the muscles don't have tumors, so we can leave them there. But then once we have the muscles removed from the eye, from the eyeball, we actually grab the eyeball with special instrumentation, and then I put some scissors behind. The eyeball is connected to the brain by a nerve that is called the optic nerve.
Yeah.
It's about 2 to 3 centimeters from the eyeball to the brain. So we put some special scissors, because we already have space there. We put special scissors behind the eye, and then we cut it.
Mm-hmm.
And then at that point, there's nothing. Now the eye is not connected to the eye. At that point, that's it. We cut the eye. Then we have to remove the eyeball from your face.
Yeah.
And then we put it in a separate table. At that point, my assistant is gonna start helping me to control the bleeding. Mm-hmm. Everything is fine in the eye. I'm gonna go to see the eye that I just removed, and I'm gonna inspect it to make sure that everything is fine, that we didn't create any problems, or that the tumor is not outside of the eye. And then we cut a tiny piece of the nerve to send it to the pathologist so he can right away take a look and see if there's tumor there. Because if it's tumor there, we know that that patient already has tumor in the nerve, and that's very dangerous. So that patient will need special treatment right away. Most of the time, there's nothing there because we did an MRI beforehand, and we know sometimes we know what to expect, right? And then we send that eyeball to the pathologist, which is the pathologist is a doctor who looks at the tissue.
Yeah.
And under the microscope, and the pathologist, what they do is that they cut the eye in tiny pieces, and then they look under the microscope and they tell me, Efren, the tumor is inside the eye and there's nothing else to worry about. Okay, perfect. So if that's the case, and the patient has only the tumor in the eye that is with the disease and nothing else outside the eye, he's cured at that point because there's no more tumor in his body.
That's great.
And that's it. So he's cured. We just need to take care of this, the prosthesis, and that's it. But that patient is basically cured. No more cancer in his body. But if the pathologist tells me, Efren, in the microscope, I can see that the tumor is invading the blood vessels, the blood vessels of the eye. It's there. The tumor is inside. Well, that means that maybe some cells from the tumor are already floating in your body, even though we remove the eye. So that those patients need more chemotherapy. So we have to tell the oncology patients team that there's some high risk characteristics, and they give them an extra chemotherapy to make sure that nothing bad happens to those patients. Okay. And then finally, I change my gloves and I put a new gloves, and then I go back to where I removed the eye, and then there's a space there, not because the eyeball is gone.
Yeah.
So then I put a tiny ball of plastic. It's called the implant. It's a prosthetic prosthesis device, which is around like a marble, but it's different. There's different materials, and we put it. So we measure how big is the socket, and we put a ball that is about.
This is much more in depth than I ever knew. So you measure the socket and you put this the ball.
So we put the ball inside the eye. So that ball is gonna take care of what the eye was there, right? Because we need it to be able to grow our face symmetrically. We need something there to make it symmetric. And then we put the muscles that remember those muscles that we just left there.
Yes.
We suture them to the tiny piece of plastic, then the tiny fake eye. And then we close the skin of the eye. And then basically when you open the eyelid at that point, you just see pink. It's just like a pink. You don't see the eye, but it's just pink. So that's something that is very important for your audience to understand, because they have this understanding or this idea that once you remove the eye, there's an empty space there. There's actually all the families that have gone through this, they said, oh, it's actually not that bad. Of course it's bad because they remove the eye, but you open the eyelid and it's just pink. It's just like skin, and so it's not as I guess gross, or it's really not. It's just pink. So then what we do is we let that heal for a few weeks. We put a patch, and mom has to put some ointment there for a few days. And then a few weeks later, we call another doctor who is a specialized in prosthetic devices. It's a doctor who only does prosthetics. And he basically, do you remember when you go to the dentist and you have to have like a piece of new tooth, and they put this gel in your eye, and they take an implant, like a implant of a sample of how your mouth is,
Yeah.
and then they do the teeth to the same size. Well, he puts exactly the same paste that you put in your mouth in your eye
Oh,
socket,
wow. So
and he
that,
takes an impression of that. So under your eyelids and in front of the skin, he takes an impression of that, and then he goes to his office, and he copies with your other eye. It's really art, because they do it by hand. They paint all the blood vessels, all the details, and then you just put it like a contact lens under your eye, and that's it. Then you have your fake eye, your implant there, and it moves because you put the muscles there, but it doesn't move 100%. So if you really put attention, you will say, oh, okay, this is really not like a true eye. But some people never notice. And what happened is that, because this happens when you're a baby, usually when you are growing up, you learn that you have that problem. So first of all, one thing that I want the parents to understand is that the baby has never a problem with this, because they're growing with this all their life. So they are not, they don't have any issues, with having this fake eye. That this is the only thing they can remember since they were little. Now, if I remove an eye of an adult right now, we will have a lot of like psychological problems. But a kid, they said, well, since I can remember that this is my
my
fake eye.
kid jumped, not my kid, but Brody jumped right back after his amputation. So
Yeah.
I can only
Yeah.
imagine.
And the babies they learn how to take the contact lens, the fake eye, and then they play with it. They show it to their friends in school. They're like, they when they are mad at mom, they throw it to the toilet and they flush it, and it's like a $2,000 prosthesis. And then or they just, mom called me and they said, we don't know where the prosthesis is. He hide it and we don't know what it is. So we have to buy another one, and it's like a pair of shoes. Every week, every year that he's growing, you have to go to the prosthetic doctor, and he just have to make it a little bit bigger. But so interestingly, when you are done with the surgery, when we remove eyes of an adult, for example, you have a patch here, and there's no pain. There's really little pain, because you don't have your eye anymore. There's no nerve connections there. So the patients, the adults, tells me that they only feel like sore, but that's it. It's just sore. No, there's no real pain. It's just like like soreness in the face, and that's about it.
Wow. That's much more involved than I ever thought. And no, but the whole muscles bit, I never thought that you'd be able to take them out and put them back, but that's fantastic. And I have seen kids with the prosthetic eyes, and they seem to be getting along just fine. And like you said, the adults have such a much harder time adjusting. I can only imagine if it happened to me. I don't want to imagine, but I can only imagine.
Yeah.
So is there anything else that you'd like to add?
Well, I mean, I just want to tell the families that are listening to you that, even if we have to remove the eye, we only do it when it's extremely necessary, of course. Nowadays, with the new technology we are removing less eyes. It's less and less and less. Unfortunately, we still see patients here in Boston from other parts of the world, from South America, from Europe, that are coming here with super advanced disease, and we have to remove eyes. So I still have to remove eyes. The U.S. People who live in the United States, usually we have the privilege to have pediatricians and doctors who take care of us, and so for the U.S. population, it's rare that this happens, but it still happens. Still happens every now and then. I would just say that trust your doctor. They are trying to help you. It's hard to, as a parent. I'm a dad, and I if somebody tells me that they have to remove the eye of my daughter, I will. I don't even know what I'm going to say. I understand that. We understand that, but we're trying to say, we have to always remember, life is number one, life is number two, life is number three. Then the eyeball, if we can preserve the eyeball, that would be great. And then at the end of the list is sight, okay? Because we're dealing with cancer. So because a lot of patients tell me, am I going to see? And I tell them, right now, my worry is that to survive, survival. Right now, I don't know if you're going to see. That's the least of my concerns right now.
Yeah.
We're treating with cancer, and we want to make sure that your son or your daughter survives, and later we can worry about sight. But I'm happy to, whatever anybody needs help or just pointers or document or questions. I work in Boston Children's Hospital, and if you look in the website, there's my name there. You can contact us. We have a wonderful team with Dana Farber. We have a whole team. We have everything that we have really around the world to treat retinoblastoma, and most babies do well as long as you guys follow the directions, come to the appointments, and just helping you.
Mhm. Yeah, definitely. And final question, how many other in the country would you say are specialists like you?
Centers? Okay, so there's actually many centers around the United States. There are big ones. There's a few in California.
Mhm.
There's in Texas, there's a big one too. There's Philadelphia, there's a very big one there. New York is a big one. Boston is a big one. In Chicago, they have a huge one. Now, there are small centers in not in the big cities that also treat retinoblastoma, and they are great actually. So we collaborate, we help them, but every now and then they need help, and they send us to a big center with us. But I would say that bottom line is, don't worry about that. Just make sure that you go and see your eye doctor or your pediatrician to make the diagnosis. And once it's made, or at least there's any doubt that you can have that, go and don't waste time. Don't waste time, because time is precious in this disease and any cancer. And then just go and they will send you to the right place. They will send you, and you will be fine.
Okay. Well, thank you so much for your time. I really appreciate it.
My pleasure.
And I think you've made a huge impact in everything that you've said. So I appreciate
pleasure.
it. And I appreciate everything you do for the kids too. That's amazing.
My pleasure.
Thank you so much.
Thank you for tuning in to Living with Scanxiety. Please subscribe to hear more informative discussions like today's. Music is courtesy of Ryan Hamner.